Hi, folks. Welcome, welcome. We are going to give it a moment or two, as we always do, to let folks join. But while we're settling in the virtual room, if you would like to say hello in the chat, let us know where you're coming from. It's always nice. We don't have too much time today for a ton of audience like questions in the beginning, although that can be really fun. So it's always nice when folks use the chat to let us know who you are, where you are, all of that good stuff. Like I said, we'll get started in a moment. Thanks, folks, for kicking us off. So folks will keep coming in. And for the sake of time and the recording, I will go ahead and officially get us started. So hello and welcome to this webinar that we titled Partnership in Care, Supporting Patients and Caregivers After Early Stage Dementia Diagnosis. My name is Ariel Mather. I'm the Senior Program Manager for the National Center for Equitable Care for Elders. We have a wonderful guest speaker today from Dementia Care Aware. We're so thrilled to be able to partner together on this session and hope that you all really learn a lot from their insights and that we have a great discussion. Hello, hello to everyone in the chat. So this is a webinar versus a Zoom meeting. So everyone is muted to prevent any background noise, but clearly we'd love to hear from you. Thanks to those who are putting things in the chat. We have both the chat and the Q&A enabled for this session. So what tends to work well, I think, is putting, just more of like observations, reflections, comments, greetings in the chat. And if you have a specific question for myself or for our guest speaker, you can feel free to use the Q&A, and that'll help us make sure we're keeping track and make sure everyone's questions hopefully get answered. We are recording this session, and we will make both the recording and the slide deck available to everyone who registered within the next few days. We usually can turn it around pretty quickly, so just know that you'll have access to that. And as always, we do provide you an evaluation link at the end of the session. It pops up when you leave the Zoom. We also email it to you. We'd love to hear your feedback because it helps inform future learning opportunities and helps us to reflect on, what went well and what we could improve for this session. All right, if you have not already been to one of our activities before, not familiar with our center, there's a lot of ways to learn about us, keep in touch with us, to put our main website in the chat. We are housed within the Harvard School of Dental Medicine, though we have a broader focus, obviously, than just oral health. But we have been around since 2017, providing free training and technical assistance to health centers and primary care associations, community-based organizations, all with the hope of improving the care of community-dwelling older adults. So we hope you'll stay connected with us. We will be able to announce several early 2026 learning opportunities very soon. So if you want to sign up for our newsletter and stay informed when those are dropped, that would be great. All right. Speaking of training and technical assistance, the Clearinghouse calendar is a really great resource for all of the various organizations that provide this type of support and education who are funded by HRSA. So I know Tiff from our team will put the Clearinghouse training calendar in the chat. If you aren't familiar with some of the other NTAPs, so National Training and Technical Assistance Providers, there's lots of great upcoming learning opportunities, so I encourage you to check that out. All right. You saw these learning objectives likely when you signed up for this session. So we're hoping you'll be able to come away from this webinar understanding, having a good foundational sense of some common challenges in early stage Alzheimer's disease and related dementias, to think about the value of care coordination and engaging family caregivers because they really are essential collaborators on the interprofessional care team. We're also going to reflect on some strategies to understand, where a caregiver is and their health and well-being, particularly during the transition period that follows a dementia diagnosis. So without further ado, let's hop into our content. So I'm going to do a little bit of level setting before I turn it over to our wonderful guest speaker today. So before we dive into that discussion, let's start by establishing some important context. We open with this pretty frequently in other learning opportunities if you've been with us before, but we know that the United States is experiencing unprecedented demographic change. By 2030, all baby boomers, those born between 1946 and 1964, will be over the age of 65. By 2040, it's estimated that we'll have nearly 80 million Americans in this age group, which is a lot higher than the count in 2022, which is about 58 million. So this growth is also reflected in the patients served by health centers, which you can see in this graphic from the NAC chart book. Patients 65 and older are the fastest growing population inside the clinic walls as well. So as older adults are increasingly seeking care in community settings, we know they bring complex and multifaceted health needs. Many face challenges with a variety of non-clinical factors of health, so limited income, transportation issues, social isolation. Health centers are uniquely positioned to address those concerns. So as the patient population ages, we must be prepared to provide age-friendly, comprehensive care that recognizes the realities of aging, including cognitive health and the vital role of family caregivers. Go to the next slide. So what does age-friendly care mean exactly? There's a few common frameworks that help us contextualize this, most of which use a series of M's. In this case here on the slide, highlighting a graphic with the geriatrics 5 M's. We love the visual of the hand. It's helpful because while these elements all focus on different aspects of health, they are all interconnected. And it's crucial that we consider the whole picture or the whole hand when working with older patients. So I'll walk through the 5 M's just really briefly. What matters is really the foundation of age-friendly healthcare. We're defining that as understanding and aligning care with each older adult's specific health outcomes, goals, care preferences, including but not limited to end-of-life care across all settings of care. Mentation, which you may also have heard referenced as mind, mood, memory, is a very relevant M for today's session. So it focuses on the prevention, identification, treatment, and management of dementia, depression, and delirium. So all of three of these D's overlap. There's lots of different M's and D's. Delirium can complicate both dementia and depression can often be overlooked in older adults if it gets mistaken for early signs of dementia. Mobility is an essential M. It relates to ensuring older adults can safely move and do what matters to them, ambulating, transferring. Really, this M emphasizes the identification and prevention of falls and strategies to maintain mobility. The medication M focuses on safety and adherence. That could include a lot of things like prescribing age-friendly medications, adjusting doses, and avoiding or deprescribing high-risk medications that may interfere with what matters, mentation or mobility, because really they're all connected. And then this 5th M of multi-complexity, I saw someone mention the 4 M's in the chat, and yes, the Institute for Healthcare Improvement, IHI, and the John A. Hartford Foundation have their age-friendly health systems framework that has these 4 M's, and they're really focused on the implementation of these evidence-based practices into a variety of care settings. And this 5th M that's contained in the geriatrics 5 M's, it really you can see it in the 4 M's as well, but the fifth here, really calls it out that there's a lot of folks that are managing multiple conditions at once. So we're really wanting to make sure this consideration is built into this high quality person-centered care for older patients. And we know that these physical conditions don't exist in isolation. So there's these interactions with mental health, substance use, social circumstances. So if you are interested in learning more about any of the M's, four or five, and frameworks to assess and guide changes to your practice, keep a lookout. So we don't have the application live yet. It'll go up in a couple of months, but we'll have a spring community of practice, so a 4-session learning series in April and May of 2026 that will dive into this more deeply, age-friendly healthcare, and improving, community-based care for older patients. So if you sign up for our newsletter, stay in touch with us. We'd love to share that information with you when it becomes available. All right, so most folks in the room have heard the acronym ADRD or AD/ADRD, Alzheimer's disease and related dementias. So as we briefly level set, it's important to remember that dementia is an umbrella term. So this is describing a decline in cognitive function, eventually severe enough to interfere with daily life. So it's not a specific disease, but rather a syndrome with multiple causes. Alzheimer's disease is the most common cause of dementia, estimated, counting for 60 to 80% of cases. But dementia can also result from vascular disease, Lewy body disease, frontotemporal degeneration, and other conditions. And some people have mixed dementia, so more than one type occurring simultaneously. So while Alzheimer's disease is the most common cause, the specific type of dementia can influence things like symptom progression, treatment approaches, and what caregivers should anticipate. However, many of the care partnership principles that we'll discuss today apply across all dementia types. The role of health centers in the identification and care of dementia is evolving as their patient populations continue to age. While the progression of something like Alzheimer's disease can vary greatly across individuals, I did want to briefly highlight some of the stages of Alzheimer's disease in order to call out those that have the most overlap, I think, with the care being provided in a community setting like an FQHC. So the progression here with the highlighted stages would really go from more of a subjective sense of cognitive changes or significant shifts in mood that can't really be explained by current life events to something more noticeable by friends and family. Eventually, with changes interfering with those more complex tasks, as we get into more moderate dementia, the number of instrumental activities of daily living that folks need assistance with will continue to grow. So the work in these more mild stages really centers around identifying concerns, making diagnoses, establishing care plans. This is a critical window where we can make the most impact by engaging caregivers early, providing education, connecting families to resources, and planning for the future. So early intervention and caregiver support during these stages can significantly influence the trajectory of care and the quality of life for both patients and their families. To that point, the next slide, earlier this calendar year, we hosted a webinar on recognizing dementia early with the help of family caregivers. In this session, we focused on really understanding the role of caregivers and how essential they are to the health and well-being of older patients. We went over factors that contribute to undetected cognitive impairment and dementia in primary care settings, and then discussed some strategies for engaging caregivers to help differentiate between age-related changes and initial symptoms of dementia. So I know Tiff put the link in the chat. Obviously, don't watch it right now, but if you haven't already seen this content, welcome you to check it out. We had two wonderful panelists share their insights during that session. So just to make sure I've said caregivers a lot. I've said family caregivers, informal caregivers. Who are we actually describing when we say that? It's pretty broad. Informal caregivers are typically unpaid individuals, usually family members or friends who are providing assistance to someone maybe with a chronic condition, disability, age-related needs. In the context of dementia specifically, these caregivers take on enormously varied and evolving roles. So there's a few different images here, certainly not a complete snapshot, but an informal caregiver could be a spouse providing companionship and medication reminders, could be an adult child managing medical appointments while they're also juggling maybe full-time work and parenthood, a sibling handling financial and legal matters, potentially from a different geographical location, maybe a grandchild assisting with transportation and grocery shopping, or a neighbor checking in daily and helping with meals. So their responsibilities can really range from occasional help with instrumental activities of daily living, so transportation, finances, meal prep, to more round the clock assistance with basic activities like bathing, dressing, eating as the disease progresses. So it's crucial to recognize there is no one singular caregiver profile. They span ages, relationships, living situations, and levels of involvement. Um, some have really robust social networks, others feel isolated. What they share, though, is that they're providing essential, complex care, often without training, adequate resources, or even recognition of their own health needs. So, understanding these variations can hopefully really help us provide more tailored, effective support. All right, we're going to tie in together everything we just discussed before I turn it over to our guest speaker. Why is incorporating caregivers into the care planning, into the care team so critical, and how does that fit within an age-friendly health system? When we actively engage caregivers as partners, we see better outcomes for everyone. So patients have improved medication adherence, fewer emergency room visits, better management of symptoms, enhanced quality of life. Caregivers who are brought into care planning might feel more prepared, more confident, and experience hopefully a decrease in feelings of stress or burnout. Of course, caregiver engagement isn't just relevant for dementia care, it's essential across all conditions, particularly for older adults who are managing multi-complexities. To that point, I wanted to offer an example of a model that incorporates concepts of age-friendly care and the vital role played by informal caregivers of older adults, which is the Caring for Caregivers model, developed by the Rush University Medical Center. I know the text in this graphic is small, but there are several areas that specifically call out the M's of what matters: medication, mentation, mobility. The foundation of this model is really clear and consistent communication that can help improve the identification, understanding, and support of family caregivers within the health systems. So, by inviting caregivers into care planning conversations, we're hopefully not adding to our workload. We're gaining essential partners who can extend our capacity to provide this whole person age-friendly care. And importantly, when we support caregiver well-being, we're investing in the sustainability of our entire care system. With that, I am thrilled to turn it over to our wonderful guest speaker. I'll briefly introduce her and let her take it away. Dr. Anna Chodos is the Executive Director of Dementia Care Aware, which is a program that supports primary care providers across the country with education, tools, and support to improve dementia detection and care. She is a professor of medicine in the Division of General Internal Medicine at the Zuckerberg San Francisco General and the Division of Geriatrics, both within the Department of Medicine at the University of California, San Francisco. Her clinical work is in outpatient specialty care in geriatrics and dementia care, and her academic work is focused on understanding the unmet needs of older adults who are seen in primary care, especially those living with dementia. So there's really no better person to help guide us through some of this conversation today. And I'll come back on for us to have a discussion at the end. But for now, Anna, take it away.
Thank you so much. Thank you for having me. Already such a great discussion and of like the issues and the topics that we're going to, in a way, I think really revisit in the information I'm going to present. So I was thinking about it as you were talking. So much of this stuff is not really a linear conversation. It's really, we're kind of like spiraling or circling around the same topics and learning a little bit more each time or going a little more in depth each time. And you've already had additional webinars on some of these topics, so I think it all kind of complements each other and more hands on the elephant kind of thing. Like we're just getting a more complete picture of these issues around early diagnosis and engaging caregivers in care. Also, shout out to all the like people from all over the country are on this webinar. That's really amazing, including very locally here in California, in the East Bay. So nice to see folks from Asian Health Services and other folks from California. So just very cool. It just makes me feel like super grateful for being here. So Dementia Care, where you're going to hear me talk about this a lot, is one of our programs. And then we have a sister program, Caregivers as Partners in Care Teams. And those are the two kind of bodies of work and the kind of stuff that we do in those programs that you'll hear me talking about today. And I'm going to be coming back on these themes of like how we engage caregivers early and how we also continue to build our skills, our practice, our expectations of earlier detection and earlier diagnosis. And that's really with the goal of better lives and better brains and better healthcare overall over time, not just, some like, it's not really, it's not really, because of there are things like newer diagnostics or newer imaging. I think people get pretty excited about that, which is great. But it's really because from my experience and from the evidence that people really need and want earlier care for this condition. Okay. Thank you. Sorry, I forgot I'm not advancing. And so this is our funding source. Early on, we were funded by what's called Medi-Cal in California. Their formal department name is California Department of Healthcare Services. We're very happy to share the slides, but if you're going to distribute them or use them for teaching yourself, just check in with us. That would be great because they're, partly property of the state of California. So thank you so much. Next slide. So we already talked about this a little bit. I thought already built such a great case about why early detection is probably helpful and doable and important, again, especially to people living with the condition and caregivers. But I'm going to add some evidence to that. So we can go to the next slide. And we already sort of talked about the population demographic. So I think the sort of like thing to know, of course, is this is a incredibly strongly age-related condition. The risk factor is primarily older age. And that's really, really true in people who are in the oldest age ranges. And that is the group that is living longer and therefore growing proportionally much more than even the other older age groups. So it's just something we're going to see more, and it's going to be more and more common. Rule of thumb is generally about 1 in 9, 1 in 10 people over 65 have Alzheimer's disease or related dementias. In the 80 plus, 85 plus population, it's more like 1 in 3, 1 in 2. So keeping that in mind. Okay, next slide. So the thing that I guess motivates me in large part is when you talk to people who live with dementia or you talk to caregivers, they really do, in various studies, survey-based, qualitative, for the most part, they'll say things that, they really would want to know as soon as possible. And the reason I think that helps motivate me is one, our systems, generally speaking, our practice is pretty far away from that. We're not really set up on any sort of population-based way to be detecting early. And then I think there's also this notion, and it's not by any means unfounded, but that people, the stigma and the fear of this condition really means people don't want to know early, or like, that's not a goal. Maybe, sure, they could know early, but it's not like that's the driving thing. But if you ask them directly, most people will say they would want to know as soon as possible. And so that's true of like sort of your general well population, just people like without dementia. So that's the first number. 91% of people without dementia would want to know as soon as possible. Also true of people who are in the process of getting evaluated for cognitive concerns, though a little lower. And just, I think we can all imagine some of the upsides to knowing earlier, but some of the things that come out of folks' ideas and minds are that it feels like they have more control. It's an issue of their own autonomy and to know what's going on with them in their bodies. And then it's just a time factor. So that means they have more time, particularly more time with a better cognitive status and better brain to plan for the future and to plan with family and to get things in order. So next slide, please. I think from the medical side as well, something I will hear from people occasionally, and maybe more than I would like, is that it's not really clear from a clinical or medical perspective what we would be doing differently if we detected it early stage, like very mild, very early versus kind of early versus moderate versus severe. Like, what's the difference here clinically? Well, one is I think we know that we just kind of engage with patients differently, or we could, if we used a 4Ms approach that really understood that at the heart of the care plan for this person is the fact that they have dementia. And we would be doing certain things differently and better. So perhaps, and I think you guys can probably think of some ideas as well. Feel free to share them in the chat. But like, we might be engaging with them differently on shared decision making, ensuring that we're using additional tools to help them understand what decisions are in front of them. We might structure treatment plans, medication plans as, simplify things or even reduce things. Always a goal in geriatrics, but in the case of dementia, it's really, there's an adherence and it's just a management issue that comes into play. So we'll do things like just schedule stuff so it ends up in the Medi set instead of all these PRNs. We'll go from 3 times a day to 2 times a day, wherever possible, 1 time a day, just simplifying things. The other piece is supporting people in all that, like once you're a certain age, frankly, a lot of people will tell you it's a part-time job just to stay on top of your own medical care, all the appointments, all the just quick checks, make sure everything's okay, or managing other serious conditions, connecting your resources and services, which can make all the difference in this condition. We might help with additional reminders, a care navigator, other resources might be brought to bear. And again, just think about how you might practice differently or how your system might, knowing that someone has a cognitive disability versus someone who doesn't. Okay, next slide, please. That's like the practical side, right? But now there's actually the medical side. And there's kind of 2 ways to think about it. There are more and more data-driven, evidence-based interventions for people with early dementia, moderate dementia, or to prevent dementia, so people who are high risk but asymptomatic. And they target what we know are the modifiable risk factors. A lot of this comes out of this regularly updated and published like mega paper that comes out pretty much every 2 years or so from the Lancet Commission on Dementia Prevention, Intervention, and Care. And they update it with newer evidence about what is really known about attributable risk factors for dementia and what are modifiable and what aren't. So you see this kind of like squiggly roadmap here, this mountain range roadmap. And it's mapping out at different life stages, early, middle, and late. What are the modifiable risk factors according to the evidence? And a couple of take homes I just want you guys to see. I know that this is, a packed graphic, but 45% of risk factors for dementia are modifiable. So they're lifestyle, they have to do with the one of them is early life education, so exposure to education and essentially that concept of building cognitive reserve. And then there's risk factors that have had shown some evidence in middle age and some in late life. So it turns out that there's good observational data for a lot of these things as well. If we're modifying them in people with symptoms, with dementia, that their disease progresses more slowly. And just to put it out there, there's obviously different causes, neurodegenerative or actual diseases of the brain that cause the dementia syndrome that we end up kind of lumping together. But particularly for several of them, we know these are neurodegenerative diseases that are actually 20, 30 years in the making. And so a lot of what is preventing dementia is really extremely preclinical, neurodegenerative disease that's being intervened on by these risk factors and that we can modify. So it is kind of it's a little bit strange to think about perhaps, but it is kind of in the same bucket, preventing dementia and slowing down, improving the rate of progression of dementia. And so both of those camps benefit from addressing these modifiable risk factors. So the big point there is there's a lot of them. There's a lot we can do. This is like geriatrics, 101, which is most things are multifactorial. So we try to address as many factors as we can. And some of the highlights are really in midlife. Hearing loss is a very potent risk factor. Also, again, for accelerating brain decline and cognitive decline. High LDL, another really big one. And then later in life, social isolation. And you can definitely enjoy looking through all of these things. But I think all of us have increased awareness probably on this webinar about the importance of those factors in preventing and slowing dementia. Okay, next slide, please. So I'm going to talk about Dementia Care Aware and how we kind of are trying to be just one of the many forces out there helping primary care in particular, but really any setting. We've done this in community settings like community organizations, and we've done it in more like PACE style programs or other program of all-inclusive care of the elderly, or more higher risk populations. You could even consider it in something like a hospital setting, but that's complicated. But our goal is just to increase the capacity, competency out there of folks to do early detection. And so we have a ton of training and education, and you'll see that kind of come throughout. So next slide, please. So so Medi-Cal actually named this assessment. It was an approach, an assessment that they created as a new benefit in their program in 2022. And we were very fortunate to get the project, as it were, to really implement this. So working with our experts in dementia, in caregiving, in all sorts of aspects of really dementia diagnosis and care in all disciplines, we came up with this thing called a cognitive health assessment. And it's meant to be an annual screen that does a quick check on cognition and function. Quick is an operative word here. And the two is operative because the dementia syndrome is only really diagnosable at some point when we have information about both, and both of these things are really intervenable. And it's not bolded because it's not the clinical part of it, but we added really early in this program, in this cognitive health assessment, and a check on, do they have a caregiver? And the reason is trying to embed a notion that this is key, this is foundational to understanding that person's situation, how they're getting care, what kind of care they might still need, what kind of support the care they are getting, the caregiver is going to need. It's a way to sort of build a structure to what might lead to a diagnostic evaluation if the person's positive. But so it's kind of starting it, but it is not the full diagnostic evaluation, of course. And then it's a pretense, really. It's a moment where we can say we're prioritizing your brain health, given that you are at an age that just becomes higher risk for stuff going on. We're going to check your brain health with a cognitive and functional screen. We're going to check on if you have a caregiver, because that's important to know. And then we have lots of things we can do. So all those modifiable risk factors I just kind of started to point out, we lump those together in a intervention idea. So a brain health plan that people should get, particularly if they have symptoms. The other thing about the cognitive health assessment, as you'll see, none of it needs like a long training or needs to be certified or has to be done by a particular team member. This could be done really by anyone on a healthcare team. So next slide, please. So the basic parts are 3 parts. We wanted it to sync with things like annual wellness visits that a lot of people do, or in the case of, in our state, Medi-Cal or Medicaid, they had a requirement to do a survey, like a quick annual survey with different age groups had a different survey. And so a brief patient history means really, really brief. That means incorporating, as is done in the annual wellness visit, often one question about how your brain is doing. Then use screening tools that are validated for cognition and function. Again, broadening the screen a little bit in that sense. And then asking if they have anybody in their life that helps provide care. So those 3 steps. Next slide, please. So the one I want to focus on is the part two, like what the screening tools look like, because just give a little bit more explanation. So as I mentioned, the history could be just incorporating, have you noticed any changes in your memory or thinking? That's like often the question in an annual wellness visit or on a screener, like, have you noticed any changes? If that's what your primary care clinic does. But the screening is where people get like, what tools should I use and all of that. And it is unfortunately one of those things, like if we're going to screen for a thyroid problem, we know what we're going to check. We're going to check thyroid stimulating hormone. Like there's not a list of a bunch of options. And the tricky thing about this area, of course, is there are a lot of options. That's actually a good thing. So we want to know who our patient population is and match it to the tools we're using. There is not one test that's going to be good for every patient population. On average, the patients I see have pretty low educational attainment, like a few years of elementary school is usually is like a very common scenario. And it's like so regionally dependent. Where did they grow up in the world? What is their gender? Were they in a city or a rural area where they grew up? These are the kind of things that we see clearly influencing educational attainment. The other, though, is culture and language can affect testing. So the goals here for the tools that are in this kind of toolbox, if you will, are that they're really short and that for the most part, they've shown good evidence across diverse populations. You could always do something different, but the goal is screen for cognition and function with validated tools. You'll see, though, that the columns also give us another way to do this, and this is to be efficient in a very busy clinical setting, right? So you could also, a ton of tools, particularly in the dementia world, are actually validated for symptoms and dementia in the patient, but having been given to a caregiver or an informant, somebody who knows the person. So that's an opportunity to like extend our bandwidth a little bit and have the caregiver or care partner like do a survey as well. A lot of people really like the 88, which is 8 questions, yes or no, about symptoms in the person. For example, as a cognitive screening tool. A lot of people know the mini cog, and it's really, really short, and it's been done. It's great flexibility for language translation, particularly if you're language concordant with the person you're assessing. And then for function, really an ADL, IDL, that's sort of the gold standard assessment. So it's kind of getting a lot of information there. But so doing a checklist with the patient or with some input from the care partner, or there's other options for, frankly, much shorter, quick checks on some key functional items. One thing you'll see is something called GP-COG Part 1 and Part 2. It's a primary care screener developed in Australia, general practitioner cognitive assessment. The first page is for the patient and frankly is a lot like the mini cog with like a couple extra questions. And then the second page is for the informant, and they answer questions about cognition and function. So I know I really went through that like in detail, but the idea here is that you have a plan to screen for cognition and function, and that you can do that with the patient or the care partner. And in all cases, they're about as short as they can be. Next slide. Okay. And then I'm talking to the patient about brain health. I'm screening them with a clock drawn, remembering a few words. And then I'm just seeing, do they have a care partner, a caregiver in their life? And sorry, the terminology is mostly caregiver, but we developed a lot of this in a brief window where care partner was heavily favored as the term. But basically, throwing in a question as well that you're comfortable with, that you get really good at about, I ask everybody, do you have anybody in your life that supports you with your medical care? Or for example, have you designated someone in like an official capacity to make medical decisions for you in case you're ever unable to? For example, we call that like a durable power of attorney. So those are different ways to ask it, but it's not even like, okay, what do they do for you? Blah, blah, all the details, which of course we want to know at some point, but it's really just like that quick check, just like with cognition and function. This doesn't give us the diagnosis. It doesn't give us the full picture. It gives us a sense of what's going on and is flagging people for those that we need to go deeper with at another visit. Okay, next slide, please. So how you might interpret the cognitive health assessment, at least in terms of like who's higher risk for maybe they are should be lumped into a group that is more likely to have dementia versus not. If they have symptoms, if they have a positive cognitive screen or a positive functional screen, those would all be reasons to essentially schedule a follow-up appointment to do more workup. And then again, this idea of starting a brain health plan out of the gate to start addressing some of those modifiable risk factors. Because the thing about that is we know it helps everybody's brain do better. So if they don't have symptoms, or if they don't end up having dementia, it would help them prevent dementia. If they do have dementia or mild cognitive impairment, then it would help them slow progression. And for most of these risk factors, it's all irrespective of the underlying neurodegenerative disease. So these really are sort of like generic brain health maneuvers. Okay, next slide, please. And so just to acknowledge, like it can be really, there's a lot of information whenever you're kind of thinking about dementia, and many of us, unless we do it all the time, feel like it's a little overwhelming. But just thinking about like the overall trajectory of or sort of like the pathway, if you will, of like how we're going to care for somebody. And in one sense, it's like really knowing your population. Is this a particularly high risk population, maybe even at ages younger than 65? So populations who have experienced homelessness often have much higher levels of cognitive impairment for a bunch of reasons at earlier ages. But then we sort of get on the pathway of screening, diagnosis, and then getting after screening people, having a plan to do a diagnostic workup of some sort, and ultimately focusing on ongoing care planning, ongoing treatment and management of symptoms. But throughout, beyond just like a population health approach, at all levels of screening, diagnosis, and care planning, where we want to be identifying and working with the caregiver and supporting them and doing brain health, general brain health work to support the health of their brain. So next slide, please. So this is sort of the framework that we use with a kind of a sister project, called Dementia Care California. So obviously I don't have time to go into the whole thing. Dementia Care Aware, a lot of our stuff you'll see really is focused on this, like getting early detection embedded in clinical practice, supporting practices to do detection. And then Dementia Care California is really like the whole clinical pathway. So that's dementiacareca.org, and has sort of this framework of detection, which would be screening, diagnosis, which is like, how do I do this workup? And then what does it look like to just do ongoing care for people? And underneath care is a whole section on caregivers, of course. Next slide, please. So I know I've been going like brain health plan. Just really briefly, the take homes to note is like, it's kind of 4 things. And these are all things that really overlap, I think, with what's out there now that people kind of know, like heart health, body health, general health. So things like social and physical activity in managing the cardiovascular risk factors. So, finding something that people can engage with physically and socially, cognitively. There's no one, brain test on the internet or whatever. And then these vascular risk factors like LDL, blood pressure, and diabetes are all very, very valuable targets for improving brain health. And then the things that we can be a little more helpful with on the medical side are reviewing medications, because there's so many that make cognition worse or even accelerate cognitive decline. And then, so getting those off the med list and substituting those. And then screening for hearing and vision. So I already mentioned the potency of hearing loss. Vision is also really, really important. So that sensory loss, for some reason, has this really potentiating factor on risk. Okay, next slide, please. And then one thing that was really highlighted at the top of the session is like, how do we engage caregivers? And I think one piece is really how we're acknowledging them. So first of all, just acknowledging them. There's so much of healthcare, right, where we're just like assuming things about caregiving relationships. So if somebody comes in the room, we just kind of assume they're a caregiver. But how do you think about how you might engage a caregiver in a way that really preserves the dignity of the patient, the dignity of the caregiver, doesn't make assumptions that the person really identifies as a caregiver or particularly feels they're a caregiver, even if they are accompanying them to a medical appointment, which is a key role for a caregiver. But for example, I always say, I walk into the room, always introduce myself to the patient, say, who's with you? Great. Should they join us for this visit? Would that be helpful? Great. And then, please remind me, their name. Okay. So and so, this is great. Really nice to meet you. Sounds like you'll be joining us for the visit, or maybe we can split up for a while and then we can come back later if that's helpful. And so just really acknowledging that and not like jumping and making assumptions. I think that is one key piece. And just think about these questions like, how do you right now think about identifying caregiver needs and caregiver role and needs? And I'm now going to go into some more content about that specifically. So next, okay. So some best practices particularly around communicating with caregivers, especially when we're working on early findings of either a positive screen, or in this case, that the title here is like really once we've gotten to a diagnosis and we feel like, oh, we have all the information we need and we feel comfortable giving this person a diagnosis. One message that we know is not present when we ask patients and caregivers is any kind of support. So a really big missing piece is if we're working with somebody with this condition, making sure to say, we want to be really proactive about this condition. It often has a lot of symptoms. So we're going to review those and we're going to address those. We're also going to make sure we have your brain health as part of our plan, as part of what we're doing here to support you. And we just happen to know that for almost everybody, whoever's in their life that's supporting them in any way, big or small, if we can support them in having resources, education, and just being able to be part of this conversation, we know that you will actually, like, your health will be better. You'll be in the emergency room less often, things like that. So that's why I want to talk to Karen, who came with you today, or Lanzell was the caregiver I just talked to, things like that. The other thing is, healthcare can only do so much. And really a lot of what's going on for caregivers and people living with dementia is the life stuff. So early and often referral and emphasis on community organizations you like. Often it's something like a local Alzheimer's titled organization or an area agency on aging, a department of aging in your community. But, just pointing out, like, I know with this condition, there's so much life planning that needs to happen, like kind of life, like even if you don't have any what you think are assets, you have benefits. Those are huge assets. So planning durable powers of attorney, an advance directive. We have so many good free organizations for people who are older with dementia, or just because they're older, who can provide some free legal counseling. And the sooner you do that, the better. So I don't really try to like get too into the details because I don't do that work and I know I'll mess it up. But I do try to make connections with the community organizations that do the work and understand how they would want to represent their services and understand what the person could expect going there. And then if I have somebody who's gone there, I get some feedback and like, were they able to work with you? Was it easy? Was it confusing? And in that way, I can figure out if this is an organization that feels like a good fit for my patients and as a general rule. And then finally, right now, they're kind of scattered. And so I put a map. If you Google CMS or Medicare guide dementia program, you might be able to find if there is a guide program. And this is a care navigation program that's on a pilot basis. So it's not globally available or, nationally available. But it is in a lot of areas and could be one of these resources that's a little more hands-on and dementia focused. So just wanted to highlight that resource in some communities. Okay, next slide. I know we're getting close to time, but there's a way that we can build more skills in dementia. So in caregiving assessment, in dementia and outside of dementia as well. But so we have a sister program, carepartners.ucsf.edu is the website, but it's called Caregivers as Partners in Care Teams. And we kind of do the same thing we do in Dementia Care Aware, which is we have live and online trainings that really go through more of the skill set to identify, educate, and support caregivers. So for the next slide, and there's our beautiful QR code, excuse me. The key principles here are identify who the caregivers are and what they're doing. So it's kind of like a little bit of a detailed, map of what's going on. Engage them in their needs. And there's really kind of two pieces to that. It's their well-being around the often emotional demands of a caregiving role. So that's something that has been a huge focus of research. And I think sometimes we can overemphasize it as burden. And not a lot of people necessarily frame it that way for themselves, but they will engage around discussing and detailing how the work affects them in an emotional way. Like a status change in their parent is a really hard thing. A change in their spouse is a really hard thing. How are they managing that? And like what kind of mental health and other community support tools do they have to manage that kind of stuff? The other piece is actually job skills. So many people jump into the caregiving role without any kind of formal transition into that role, no real job training, like, oh, now I have to help her reorient her constantly because she has no idea that we made these plans or that we moved her to a new apartment 6 months ago. How do you manage all that? So these are real concrete skills. And often there actually are these like caregiver skill resources, YouTube, online classes, Alzheimer's Association, day-long caregiver training sessions, books. How are we helping them identify the concrete skills they need? Because like with any job, and we don't have to refer to it as a job, but with any role, if you don't have the skills you need to do the job, but you're trying to perform at the job, that's literally the classic scenario of burnout. And then finally supporting by as we're picking up on what job skills they may lack or may think they need. And the emotional skills is like having at the ready kind of who are my community resource people that I would refer to, or internally in a health system, do you have a social work team that's really good at this? Okay, and the C4C program is a classic example, which you already mentioned. Next slide. So this is just some examples that like I might use, and these are nationally available examples, which is why I put them up here. Clarity is an online site to do the legal planning piece so people can do it themselves, establish durable powers of attorney for finances. That's pretty tricky. And so often in the past, we have recommended that people work with lawyers, but it's also really inaccessible for a lot of people. And this was developed by elder law experts and medical legal experts for dementia and older adults specifically. So I would check that out. They also have a pro section for healthcare providers and teams that want to learn more about these things so that they're sort of bridging that gap as well. So planforclarity.org. And then there's prepareforyourcare.org, which is the healthcare medical legal preparation side, the advanced directives. And in both these cases, they're set up to address the needs in all 50 states. Alzheimer's Association is kind of a general clearinghouse for support, information, finding groups in your area that address dementia and caregiving. And finally, Family Caregiver Alliance, also really fabulous. So many generally relevant tools, although they are a local California organization as well. Next slide. And so we love education. I hope that's obvious. We do so much training around early detection of dementia, going deeper into how to do the screening, how to modify the screening, think going into the next steps work. So if that's something that might be useful to your organization or to you, you can peruse our online modules or reach out to us. Same thing as caregivers as partners and care teams. Both of these have a lot of free CE and CME. And obviously we're just like a very synergistic program with this program. So, which is also fabulous. So we're all out there and there's so much need. So it kind of depends what works and what, everybody's schedule is. We have a lot of California-based timing for our programs. And then finally, just the resources at Alzheimer's Association and Clarity for really doing work to build resources internally in these areas in healthcare. Okay, next slide. And that's it. And I do really welcome any emails, any questions about this work, about the issues I brought up. And I hope we do have, if the clock I'm looking at is correct, we have a few minutes to have some conversation.
Yes, thank you so much. We'll give it a minute for folks to put questions in the chat. We can stop screen sharing. Juliet, thank you. Yes, we'll be giving everyone the slides to answer the question in the Q&A. We'll make sure everyone gets the recording and the slides within the next few days. So you will have that. While folks might be reflecting on other questions, you might have seen before we stopped screen sharing, there was a few discussion questions that Anna and I had discussed beforehand to see, maybe depending on how much time we have, maybe we can have this discussion. There's a lot that you already, I think, covered, Anna, but I am curious if you have any other reflections on this is a caregiver question specifically about their own understanding of their role. So that this has come up a lot for us in various caregiving focused activities. It doesn't have to be dementia necessarily, which is we're stressing the importance of to providers and staff, like acknowledge caregivers, like incorporate them, really pushing that. And then we've had some really interesting discussion with folks saying, well, what if someone doesn't like see themselves as a caregiver, like that label, whether it's the label itself or the role of a caregiver or care partner for something like dementia. It's so evolving, and I'm sure it's overwhelming at first, even just to kind of think about what could be to come. So I'm curious, in addition to what you've kind of already shared, which I think is a lot of allowing folks to put it in their own words and just really making space for that. But any other reflections on our own understanding of what it means to be a caregiver and kind of how a care team might be orienting themselves to that caregiver in conversation?
Yeah, I think probably all of us have had that moment where we've like assumed too much and like
Mm.
yeah, like said too much and um or like just spoken as if we understand the situation. I think I'm sure everybody who's a very skilled clinician, but just like and so can kind of feel it out,
Mm.
kind of case by case. But I think some of the general principles are like, again, not making assumptions, asking really concrete things um, like how do you, take a shower or, how are you getting that done? How are you getting these things done? Shopping, cooking, and then you get the story as opposed to, oh, is Sarah helping you with, the daughters like there? So is Sarah doing the shopping, blah, blah. Or, I think the other question is often like, do you need help with, or just ways that instead of just letting people like kind of organically tell you how it's done and seeing how they're framing it as opposed to giving them the words of like, you need help or are you dependent
Mm.
on or blah, 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 which can be more infantilizing to the patient, but then also assuming of various roles. The other thing is, just being really upfront, like, oh, okay, well, you've told me you really help her with getting to appointments, you track her meds, you make sure her house is stocked with food. I would call all those things like caregiving and might
Mm.
say, like, you're a caregiver. Does that sound right? Does that feel right? And I don't really personally get really hung up on terminology. Like another example is a lot of patients will not accept the term dementia. That's fine. You know, we're noticed like the fact that you've lost your keys a bunch of times. What are we going to do about that? So it's really more about like the concrete implications
Sure.
and working around that. And hey, there's a course on, how to like work with somebody who's really starting to refuse medications and refusing doing things. Do you think that'd be helpful to you and how you're supporting your mom right now? And just, yeah, just not like forcing the language, but focusing on what the actual needs. And that is actually the point of identifying the caregiver
Yeah.
is really broad options for how things are getting done and letting them fill in the blanks
Yeah.
and then finding where you still have gaps and understanding what's going on and asking pointed questions.
Amazing. Thank you. Um, It doesn't look, I think that we offered so much information, and Anna, you provided so many resources for folks to jump right into after this that there aren't any other questions. And that's great because we're at the end of our time. But thank you so much for your time and your insights. And thanks to all who are here live and will watch the recording. Please keep in touch and please do give us your feedback in the evaluation link that will pop up shortly. And I think we'll put it in the chat as well. But take care, everyone. Thanks again for joining us, and we look forward to seeing you again soon.
Thank you.